Okay, let's dive into something truly fascinating today. Imagine a neurosurgeon right in the middle of an incredibly delicate brain operation trying to remove this really aggressive tumor called glioblastoma.
Hmm.
Their biggest challenge, I mean, the one that really keeps them up at night, is knowing exactly where that tumor ends and the healthy, vital brain tissue begins. You see, current tools often fall short,
They really do.
leaving maybe too much cancer behind or, just as dangerously, taking out too much healthy brain. But what if there was a new kind of, let's call it super ultrasound, something that could give them a real-time color-coded map, not just of, lumps and bumps, but of the microscopic differences between healthy cells and cancerous ones. That's the cutting-edge world we're
I find
exploring.
this fascinating.
We're talking about Hermite scan or H-scan imaging, and this isn't just like a small update to existing tech. It's a fundamentally groundbreaking technique being looked at really closely for its potential to precisely differentiate glioblastoma from normal brain tissue during the surgery itself.
Right, intraoperatively.
Exactly. Our main guide for this deep dive is a really powerful paper. It's titled Hermite Scan Imaging for Differentiating Glioblastoma from Normal Brain: Simulations and Ex Vivo Studies for Applications in Intraoperative Tumor Identification by Kakar and colleagues, published in the Journal of the Acoustical Society of America back in December 2023.
A very recent and important study.
Absolutely. So our mission today is to really understand how this H-scan works its magic, what the sophisticated simulations revealed about its unique capabilities, and how these initial studies on actual tissue samples are already showing its, well, profound potential for guiding surgeons right there in the OR. Think of this as your shortcut to getting up to speed on one of the most exciting developments in neuro-oncology right now.
And what's particularly compelling here, I think, is that this isn't just another imaging modality producing, another gray picture. H-scan takes a qualitative approach. It actually extracts information at a level often entirely missed by conventional methods. It's a bit like tuning a radio very precisely to hear a specific frequency hidden within the static. We're going to explore how this technology could potentially address a critical, long-standing unmet need in neurosurgery where precision isn't just important, it's literally life-altering.
So let's start with the big challenge here, glioblastoma, or GBM. This is an incredibly aggressive primary malignant tumor of the central nervous system. I mean, when we talk about GBM, the statistics are just stark, really sobering.
Mm-hmm.
Patients face a poor overall survival rate, averaging just 18 months, and that's even with the most advanced maximal therapies available today. When doctors are faced with GBM, the absolute cornerstone of treatment is maximal yet safe surgical resection.
That's the key phrase, maximal yet safe.
Exactly. It means removing as much of the tumor as humanly possible while meticulously, carefully preserving every bit of healthy brain tissue to avoid devastating neurological damage. It's the first and often the most critical step in what's usually a long and difficult battle for the patient.
Absolutely fundamental.
But here's the core problem, the huge challenge that surgeons grapple with every time. Current intraoperative imaging tools are often surprisingly ineffective at accurately assessing those crucial tumor margins during the actual surgery.
Right, in real time.
Yeah. Picture this. A surgeon has meticulously planned the operation using highly detailed preoperative scans, MRI, CT. These are invaluable for planning, no doubt.
Essential for planning.
But once the skull is open, once the pressure inside changes, the brain can literally shift. It moves. This phenomenon, it's known as brain shift, and it alters the delicate landscape inside the skull.
Making those beautiful pre-op maps less useful.
Exactly. It makes those static preoperative maps much less reliable. It's like trying to navigate a city using a map from yesterday after there's been, I don't know, a minor earthquake overnight that shifted things subtly. Researchers like Fuller and Zhang have noted this brain shift severely compromises the accuracy of image fusion. That's the process of trying to overlay those preoperative scans onto the real-time surgical field. The brain just isn't static. It moves, it changes shape, often by millimeters, but in brain surgery.
Millimeters are miles.
Absolutely. They matter immensely. And beyond the limitations of those pre-op scans, even the tools available during the surgery have significant drawbacks. Take fluorescence imaging, for instance. It sounds great, right? The patient gets a special dye, tumor cells glow under a specific light.
Seems intuitive.
It does. But for precisely defining those really elusive tumor margins, its sensitivity is often quite low. It's good for spotting the main bulk of the tumor, maybe, but less reliable for those microscopic tendrils that invade outwards.
Those infiltrative edges are the real problem.
Exactly. Then you've got intraoperative MRI. Incredible detail, no doubt, but it's incredibly expensive, requires highly specialized operating suites, and, well, because of that, it just isn't widely available in most hospitals.
Statistically very challenging and costly.
Right. And even conventional brightness mode, or B mode ultrasound, which is actually a valuable and commonly used tool in the OR.
It is used quite a bit.
It has its own challenges. While it gives that real-time view, its conventional resolution often just struggles to differentiate the very subtle microscopic boundary between normal brain and GBM tissue. This gets even harder as the surgery progresses, when tissue handling, bleeding, and maybe some residual tumor bits can make visual differentiation incredibly difficult for the surgeon. As folks like Rumack and Levine highlighted, you're essentially looking at a fuzzy line where you desperately need a crystal clear one.
You've absolutely hit on the crux of the issue there. If the goal, the ultimate goal, is truly maximal yet safe resection, which means preserving critical neurological function, minimizing patient morbidity, keeping the person whole as much as possible, then having an accurate, real-time, high-resolution picture of that tumor margin isn't just, nice to have. It's absolutely essential. We're talking about removing disease tissue from the very control center of a person's identity, their function, everything. Every single millimeter matters. And the current technological gap means surgeons are often operating with less precise, less immediate information than they desperately need. And this directly impacts patient outcomes, there's no question.
Yeah.
The stakes for patients with glioblastoma are already astronomically high. This unmet need has been a really powerful driving force, pushing researchers to explore innovative solutions, like H-scan, trying to find that next level of intraoperative insight.
So how do we bridge that gap then? How do we find a better solution that offers the kind of precision neurosurgeons are crying out for? This brings us right back to Hermite scan, or H-scan imaging. It's a tissue characterization technique that takes a fundamentally different, you might even say revolutionary approach to analyzing the ultrasound data.
It really is a different way of thinking about the signal.
Instead of just giving you that standard grayscale image based on how much sound bounces back, H-scan delves much, much deeper into the very nature, the characteristics of those echoes. At its core, H-scan works by analyzing the raw ultrasound radio frequency, or RF echoes. These are the unprocessed sound waves bouncing back from the tissues, and they carry all this intricate information that needs decoding. Imagine you have a complex sound coming back, right? H-scan is like having a highly specialized decoder ring for that sound.
That's a good analogy.
It dissects these echoes by matching them to a specific set of mathematical functions. These are called Gaussian-weighted Hermite polynomials of various orders. Now, think of these polynomials as a finely tuned set of mathematical lenses, or maybe filters.
Yeah, filters is a good way to put it.
Each lens, each filter, is designed to extract a different kind of information from that ultrasound echo specifically. Details related to the scatterer diameter within the tissue. Now, what are these scatterers? Well, they're essentially the microscopic structures inside the tissue. Things like individual cells, maybe cell nuclei, tiny clusters of cells, even things like collagen fibers that cause the ultrasound waves to scatter, to bounce back. And their size, their distribution, can tell us an incredible amount about the tissue's underlying health, or in this case, its pathology.
A microstructure, essentially.
Exactly, the microstructure. And here's where it becomes incredibly intuitive, potentially, for the surgeon right there in the operating room. H-scan presents its findings as a distinct color map. It's not just abstract numbers or a grayscale.
Right, it's visual.
It's visual. Areas dominated by larger scatterers are typically represented in the red channel, giving those regions a reddish color. While areas where smaller scatterers are more prevalent are mapped in the blue channel, making them appear more bluish. This color coding gives the surgeon, or the diagnostician, an immediate visually distinct picture of the underlying tissue microstructure, highlighting differences that might be completely invisible to the naked eye, or even to conventional ultrasound.
And if we connect this to the broader landscape of tissue characterization techniques, H-scan really does differentiate itself from others you might have heard of, like, say, backscatter, coefficient imaging, or spectral feature extraction methods.
Okay.
A really significant advantage, and one that's absolutely crucial if you're thinking about actually using this in a busy OR, is that H-scan does not require calibration of the ultrasound probe and the imaging system.
Oh, that sounds like a big deal, practically.
It's huge. It dramatically simplifies its use in a clinical setting. It removes a major practical hurdle for adoption and makes it potentially much more plug and play,
Yeah, much easier to integrate.
Much easier. Furthermore, while each scan is predominantly qualitative meaning, it focuses on relative dimensions and differences rather than giving you absolute precise measurements of scatterer size in micrometers.
Right, it's more about the comparison.
Exactly, it's about the comparison. But it offers something truly remarkable. Higher spatial resolution compared to many other kernel-based methods for tissue characterization. This improved resolution is incredibly crucial for distinguishing those very fine, often ambiguous tissue boundaries that are so characteristic of aggressive, infiltrative tumors like glioblastoma. It allows us to see smaller changes more distinctly, giving surgeons a finer, more detailed map.
A clearer line.
A clearer line, hopefully.
Mhm.
And this isn't just some untested concept pulled out of thin air. HCAN actually has a pretty robust and impressive track record in other areas of cancer detection and characterization already.
Oh, really? Like what?
Yeah, it's shown prior success in a variety of applications, demonstrating its versatility and reliability in differentiating normal tissue from cancerous tissue, and even in assessing cancer progression. For example, it's been successfully used to identify normal, benign, and malignant thyroid tumors and breast tumors in vivo, meaning in living patients.
Wow, okay.
It's also proven effective in assessing pancreatic cancer progression and treatment response, and even distinguishing different types of melanomas in animal models. There are studies from researchers like Carol Seed, Ouyang, and Bayek that highlight these successes. This consistent performance across different cancer types and tissues really establishes a strong foundation, a proven track record for the technology. It gives us significant confidence in its potential for brain tumor applications, too.
Okay, that background is crucial. It shows it's not just a theory. But now, to truly appreciate HSCAN's power, we probably need to sort of peek under the hood a bit at its ingenious algorithms and understand a key parameter that seems to be at the very heart of its diagnostic capability. It all starts with those Gaussian-weighted Hermite polynomials you mentioned.
T polynomials.
Yeah, GH polynomials. As we mentioned, these are specialized mathematical tools. Essentially, they're a family of orthogonal polynomials that, when weighted by a Gaussian function, become perfectly suited for analyzing signal shapes, like our ultrasound echoes. The energy normalization bit just ensures their total strength or influence is standardized, which is important for making consistent comparisons later on. Think of them as like a collection of unique mathematical magnifying glasses. Each glass is designed to reveal a specific characteristic within that returning sound wave. So, for example, a lower order polynomial, like GH2, might act like a wide-angle lens, picking up general low-frequency information which tends to be associated with larger structures, larger scatterers. While a higher order one, say GH8 or even higher, acts more like a telephoto lens, zeroing in on the high-frequency components that come from smaller, finer details in the tissue.
Okay, different filters for different features.
Exactly. Now, how do these mathematical filters get turned into that live, color-coded image we talked about? Well, one of the earlier implementations is known as the two-convolution H-scan algorithm.
Right.
In this method, each raw RF ultrasound line, that stream of data coming back from a single direction of the ultrasound beam, is processed by being convolved, which is basically a mathematical way of implanting signals, in parallel with two specific energy-normalized GH filters, GH2 and GH8.
Just those two.
Just those two in this simpler version. Think of convolution like passing that raw signal through a specific kind of sieve, or maybe like adjusting a specific frequency band on a graphic equalizer for music. The GH2 filter is designed to capture the low-frequency components in the backscattered signal, and these low-frequency components are strongly correlated with larger scatterers in the tissue. This information is then assigned to the red channel of the H-scan image.
Okay, GH2 means red, means larger scatterers.
Pretty much. Conversely, the GH8 filter corresponds to high-frequency components, which represent smaller scatterers, and this information gets assigned to the blue channel. Now, to quantify the fraction of these larger scatterers, a parameter called the mean intensity of the red channel, or MIRC, is computed. It's basically a straightforward measure of just how much red appears in a specific area of the image.
So MIRC is based on that GH2 filter output.
Exactly. But what's truly fascinating here is how the algorithm evolved. While that two-convolution method provided some foundational insights, the 64-convolution H-scan algorithm offers a much more refined and sensitive analysis. 64? That's a big jump from 2.
It is. Instead of just 2 filters, this advanced algorithm involves convolving each RF line with a much more comprehensive set of energy-normalized GH kernels. Specifically, it uses even orders ranging from 2 all the way up to 128. Imagine having, effectively, 64 different mathematical magnifying glasses, each one tuned to a slightly different size or characteristic of microscopic scatterer. This broad array of filters allows the system to be incredibly discerning, capturing a much richer, more nuanced spectrum of scattering characteristics from the tissue than just using GH2 and GH8.
So it's getting a lot more detail from the
A
signal.
lot more detail. And the pseudo-coloring process then becomes much more sophisticated as well, based on which specific filter best matches the backscattered signal at each individual pixel location, meaning which filter shows the highest correlation that best fit a specific colors assigned.
Okay.
Lower order filters, like GH2, which, as we discussed, represent relatively larger scatterers, are assigned red hues. Conversely, higher order filters, like way up at GH128, representing relatively smaller scatterers, are assigned blue hues.
Red for big, blue for small still.
Still the basic principle, yes, but the intensity of that color then varies based on how close that best matched filter is to the midpoint, which is the 64th order filter in this range. So a signal that strongly matches GH2 would be a really vibrant red. Something matched way up at GH128 would be a deep blue, and a match somewhere in the middle of that range would be a more muted or intermediate color, providing this continuous spectrum of information about the tissue's microstructure. It's not just red or blue, it's shades.
Shades of red and blue, representing a whole range of scatterer characteristics.
Exactly. And this brings us to the key parameter derived from this advanced 64 convolution algorithm, and arguably the most powerful diagnostic tool we're discussing today. The intensity-weighted percentage of red, or IWPR.
IWPR, okay.
The IWPR is computed for each location based on the normalized color intensity for both the red and the blue pixels within a defined region of interest, maybe a small window moving across the image. The formula is actually quite intuitive. IWPR equals the sum of red intensities divided by the sum of both red intensities and blue intensities, then multiplied by 100%.
So it's basically the percentage of the total color intensity that's red.
Precisely. It gives us a percentage that directly quantifies the proportion of redness, and therefore the prevalence of larger scatterers in any given area. It's also complementary to the intensity-weighted percentage of blue, or IWPB. Their sum will always equal 100%.
Makes sense.
Now this raises an important question. Why is IWPR such a crucial parameter? Why focus on this one? Because it offers a robust, quantitative way to measure that relative proportion of large versus small scatterers. And as we're about to see, this precise quantification seems to give us a distinct and reliable signature for differentiating various tissue types, which is exactly what's needed for something as complex and invasive as glioblastoma.
Okay, so this IWPR is the key metric they honed in on. Before researchers could even think about applying this HSCAN with IWPR to real living brain tissue, they absolutely had to prove the concept and validate its parameters in a completely controlled, simulated environment. You can't just jump into human brains, right?
Absolutely not. Rigorous validation is key.
So they turned to sophisticated computer simulations using the K-Wave toolbox in MATLAB, which is a powerful software environment for numerical computation and modeling acoustic waves. This approach allowed them to completely isolate variables and truly understand how HSCAN behaves under perfectly controlled known conditions.
Setting up a virtual lab, essentially.
Exactly. Let's quickly look at their simulation setup because it was quite detailed. They constructed a virtual tissue sample on a two-dimensional grid, modeling the acoustics of soft tissue with standard properties like sound speed and density. To simulate the microscopic structures that actually scatter the ultrasound waves, basically, creating an acoustic model of cells, they used tiny virtual disks simulating polyethylene.
Okay.
They designed two main types of scatter distributions to test different scenarios. First, monodispersed scatterers. These were simulations where all the scatterers in a given phantom had the same size, but that size was varied across different simulations, from very small, 15 micrometers, to quite large, 150 micrometers. They also varied the concentration, how densely packed these same-size scatterers were.
So testing size and concentration separately.
Right, and they ran multiple random realizations for each condition to ensure statistical robustness. Second, they created bimodal scatterer distributions. These simulations had a mixture of two distinct scatterer diameters, specifically 50 micrometers and 90 micrometers, and they varied the relative percentage of each size, again, across different overall concentrations. This tested the system's ability to handle mixtures of scatterer sizes.
More realistic, perhaps.
Potentially, yeah. For the ultrasound transducer, they modeled it after a real-world clinical probe, an L11-5V linear array, emitting a broadband pulse centered around 7.6 millihertz, which is typical for this kind of medical ultrasound. And crucially, to ensure the results were robust and reflected the noisy reality of medical imaging, they deliberately added a realistic level of background electronic noise to all the simulated data.
Good practice makes the results more believable.
Definitely. This meticulous setup allowed them to precisely control and test how the H-scan parameters, especially MIRC and IWPR, responded to changes in both scatterer size and scatterer concentration.
And circling back to why this matters for patients, these detailed simulations were absolutely critical. They allowed the researchers to really tease apart the individual effects of scatterer diameter and scatterer concentration on the resulting H-scan images. The goal wasn't just to generate colorful pictures, they were hunting for a parameter, a metric, that could reliably detect changes in scatterer size without being fooled or confounded by how densely packed those scatterers were within the tissue.
Why is that separation so important?
Because in a tumor, both things can change, right? Tumor cells might be different size than normal cells, but they might also cluster very differently, sometimes more densely, sometimes less so in necrotic areas. We need a tool that can tell us if the signal change it's seeing is primarily due to the size of the structures or just how many structures are crammed into a space. That distinction is vital for accurate biological interpretation.
Got it. So what did the simulations reveal? Did IWPR live up to the hype?
Well, the simulation results yielded some truly profound insights, especially when they compared that earlier MIRC parameter to the more advanced IWPR, particularly in those monodisperse scatterer simulations, where they controlled the size precisely. A detailed statistical analysis using two-segment linear regression showed that IWPR could effectively assess a much broader range of scatterer diameters compared to MIRC.
How so?
MIRC's sensitivity, its ability to respond to increasing size, tended to plateau or have an inflection point at smaller diameters, somewhere between 62 and 69 micrometers. And this point actually shifted a bit depending on the concentration. IWPR, on the other hand, had its inflection point much later, between 120 and 131 micrometers. And while it also showed a slight increase with concentration, it crucially covered a significantly wider range of sizes overall. This means IWPR remained sensitive to changes even among larger scatterers where MIRC had already flattened out. It offered a more comprehensive view.
Okay, so better range with IWPR. What about the concentration issue?
That's where the truly crucial finding emerged, arguably the most powerful aspect revealed by these simulations. IWPR's remarkable concentration independence.
Independence. Meaning it didn't care how packed the scatterers were.
Pretty much. When they looked at MIRC, its positive slope, how steeply it increased with scatterer diameter, clearly increased as the concentration went up. It went from about 0.78 at the lowest concentration to 1.3 at the highest. This showed a clear dependence on how many scatterers were present, not just their size.
Okay.
But for IWPR, the positive slope varied only slightly across all the different concentrations tested, and most importantly, it showed no clear trend related to concentration. This was compelling evidence demonstrating its independence from scatterer concentration. Wow. And this was further reinforced when they looked at the bimodal distributions, the mixtures. The linear regression trends for IWPR at all the different concentrations overlapped almost perfectly. This provided even stronger confirmation that IWPR is primarily responding to scatterer size, not density. Furthermore, the statistical measures of fit, like the RMSE values, were consistently low and stable across all concentrations for the IWPR regressions, indicating a remarkably reliable and robust fit. This really reinforces IWPR as a parameter that truly measures what it claims to measure, relative scatterer size.
So what does this all mean for us, the learners, and I guess for the future of tissue characterization, especially in cancer? It sounds like the IWPR is a diameter-dependent H-scan imaging parameter that could be incredibly useful for visualizing pathological changes in tissues based on changes in only the scatterer diameters and not getting confused by scatterer concentrations.
That's the key takeaway.
That seems like a huge advantage for characterizing tissue, particularly in something as complex and variable as a tumor, where both cell size and cell density can change dramatically from one spot to another. It means H-scan via IWPR could potentially tell us something fundamental about the cells themselves, about their intrinsic architecture, rather than just how many of them are crammed into a given space. It's like, I don't know, being able to identify a type of fruit by the characteristics of its seeds, not just by how many seeds you find in a bag.
That's a very good way to put it. And there's another key aha moment here that really elevates H-scan imaging, something profound that came out of these simulations. It allows for tissue differentiation based on scatterers that are actually smaller than the conventional resolution limit of the imaging system itself.
Wait, say that again? Smaller than the resolution limit. How is that possible?
It sounds counterintuitive, right? But think about it. In these simulations, the researchers were investigating scatter diameters ranging from just 15 micrometers up to 150 micrometers. Yet the simulated ultrasound system's conventional axial resolution, its ability to distinguish two separate objects along the direction of the sound waves, was calculated to be around 300 micrometers. And its lateral resolution distinguishing objects side by side was even larger, around 600 micrometers.
So the scatterers were way smaller than what the ultrasound could theoretically see individually.
Exactly. H-scan isn't necessarily seeing individual 15 micrometer scatters, but by analyzing the complex interference patterns and frequency content of the echoes coming back from populations of these sub-resolution scatterers, using those sophisticated GH filters, it can effectively deduce information about their predominant size characteristics. It's differentiating based on the collective signal from many tiny objects. This ability to see beyond the conventional resolution limit, to extract microstructural information from objects too small to be individually resolved, is profound. It opens up entirely new possibilities for microscopic tissue characterization, maybe even during surgery. It's like suddenly gaining, X-ray vision for average cell size in a region, seeing microscopic abnormalities that were previously invisible, hidden just beyond the reach of our standard tools.
That's incredible. Okay, so the simulations look really promising. IWPR seems robust and concentration independent, and it can even give clues about sub-resolution structures. With that confidence bolstered, the next logical and absolutely crucial step was to test it on actual brain tissue, right?
Precisely. Time to bridge the gap from the virtual lab to biological reality, moving towards potential real-world application.
So the tissue sample preparation for these ex vivo experiments, meaning experiments on tissue outside the body, sounds like it was meticulously carried out. They obtained 11 glioblastoma samples from actual resected intraoperative specimens. These all came from male patients aged 30-54 with tumors located in the parietal or frontal regions of the brain. And importantly, each of these samples was histopathologically confirmed as glioblastoma by pathologists, providing that absolute gold standard for diagnosis.
Ground truth is essential.
Absolutely. For control group, they used 11 normal brain tissue samples, matched for age and location, also from male subjects aged 35-55. Now, these normal tissues weren't from the same patients, understandably. They were procured from the Human Brain Tissue Repository, sourced from postmortem patients who had sadly died in road traffic accidents.
A necessary compromise for sourcing control tissue ethically.
Right. All the tissues, both the cancerous ones and the normal controls, were collected within 24 hours after death or surgery, and then carefully fixed in 10% neutral buffered formalin. Standard procedure. And of course, ethical clearances were obtained for all samples, ensuring rigorous scientific and ethical standards were met.
Hmm.
Now, it's worth just noting briefly, the researchers assumed that formalin fixation preserved the microstructure similarly to living tissue. This is generally a reasonable assumption in pathology. Histology relies heavily on formalin for excellent preservation of cellular architecture.
But it's a potential limitation to keep in mind when extrapolating to live in vivo conditions.
Yeah.
Fixed tissue isn't exactly the same as living tissue acoustically or mechanically. It's acceptable for this kind of ex vivo characterization, but something to revisit for future in vivo work.
Good point. Okay, so they have these fixed tissue samples. How did they prepare them for the ultrasound?
To prepare these precious tissue samples for standardized acoustic analysis, they were carefully embedded in agarose phantoms. Agarose is a gel-like material. Embedding them helped to hold the samples steady, preventing movement during scanning, and it provided a consistent acoustic background, helping to minimize external variables and making the measurements more accurate and repeatable across samples.
Okay, makes sense. And the actual data acquisition, how did they scan these embedded tissues?
For the data acquisition itself, they acquired raw RF ultrasound data at 5 independent imaging planes for each tissue sample, getting multiple views. They used a sophisticated research ultrasound system, a Verisonics Vantage 128, equipped with that same L11.5E linear array transducer they modeled in the simulations, operating at a center frequency of 7.6 MHz, good for high resolution. The system was focused electronically at a depth of 14 millimeters within the tissue sample itself, ensuring the ultrasound's optimal performance zone was right on the tissue being investigated.
Got it. And what about attenuation? Did that affect things? You mentioned sound energy gets lost as it travels through tissue.
Yes, acoustic attenuation is always a consideration in ultrasound. The researchers addressed this carefully. They calculated frequency-dependent attenuation coefficients for both normal and GBM tissues, based on prior literature. But interestingly, and actually quite significantly for the potential practicality of H-scan in the future, applying acoustic attenuation compensation did not appreciably change the resulting IWPR values.
Really? That seems surprising.
It was a notable finding. There was only a very small difference, about 2.5% for normal tissues and 3.7% for glioblastoma tissues in the average IWPR estimates, whether they applied the compensation algorithm or not.
Huh. Why might that be?
Well, it suggests that perhaps for relatively superficial tissues, like maybe the edge of a tumor near the surface during surgery, or when the ultrasound probe can be placed very close to the region of interest, the detrimental effects of attenuation might be somewhat limited, at least for this IWPR parameter. This could potentially simplify its intraoperative use, maybe reducing the need for complex, real-time attenuation compensation calculations in some scenarios.
That would certainly make it easier to implement clinically.
Potentially, yes,
Mm-hmm.
though more work is needed there. Finally, for the H-scan imaging process itself on these ex vivo samples, they applied that powerful 64 convolution H-scan algorithm we discussed earlier.
The one with all the filters.
Exactly. Using those energy-normalized GH filters, even orders from 2 to 128, carefully spanning the usable frequency bandwidth of the transducer from about 5 to 12 megahertz. Once the raw RF data was processed through these filters, the IWPR was then computed for every single pixel within the defined region of interest on the tissue sample. This yielded a highly detailed, color-coded map, showing the spatial variation of scatter characteristics across both the normal and the glioblastoma tissues.
Okay, so they have the images, they have the IWPR values calculated across the samples.
Which raises the important question.
Yeah.
After all this meticulous setup and processing, what did the H-scan images actually reveal about the fundamental observable differences between glioblastoma tissue and normal brain tissue when put side by side?
Yeah, what did they actually see?
Well, to really understand this, it helps to briefly picture the histopathology again, the microscopic view, which serves as our ground truth. As mentioned, representative histology images show normal gray and white matter with its structured, organized patterns, distinct cell types, and arrangement.
Right, orderly.
Very orderly.
Mm.
In stark contrast, glioblastoma samples show chaos. Under the microscope, you see these heavily infiltrating neoplastic astrocytes. The cancer cells often packed densely. You see areas of necrosis, dead tissue. You see rampant, disorganized blood vessel growth, that's vascular proliferation. And you see significant stromal alterations, changes in the supportive tissue framework. This complex, disorganized, and often densely packed microstructure of glioblastoma provides the crucial biological basis for why H-scan might be able to differentiate it so clearly from normal, orderly brain tissue.
Okay, so the underlying biology is very different. Did H-scan pick that up? Did the IWPR show a difference?
And here's where it gets really exciting and directly answers that question.
Yeah.
The results were not just, vaguely different. They were statistically significant, unequivocally demonstrating H-scan's potential power.
What were the numbers?
The IWPR estimates for the normal brain tissue samples averaged out to 44.1% with a standard error of 1.4%. In stark contrast, the IWPR estimates for the glioblastoma samples were significantly different, averaging 36.2%, with a much tighter standard error of 0.65%.
So lower IWPR for glioblastoma.
Lower IWPR for glioblastoma. And the p-value, the statistical measure of significance, was less than 0.00001.
Wow, that's highly significant.
Extremely significant. This isn't just a small borderline variation. It's a clear, measurable, and apparently reliable difference between the two tissue types based on this H-scan parameter.
And visually, what did this translate to on the actual H-scan color maps? You said lower IWPR means less red, more blue.
Exactly. It was quite striking visually. The H-scan images generated from the glioblastoma samples consistently had less red component compared to the images from the normal brain tissue samples. They appeared distinctly more bluish overall. This visual difference, directly reflecting the statistically significant lower IWPR values, is a powerful indicator of H-scan's diagnostic potential to literally highlight the tumor tissue differently from the surrounding normal brain.
Okay, so we have lower IWPR, more blue appearance for GBM compared to normal brain in these samples. What does this all mean biologically? How do we interpret this finding for understanding glioblastoma and, more importantly, for potentially improving surgical outcomes?
Well, the findings paint a pretty clear picture, interpretation-wise. That observation of less red or a more bluish hue in the malignant glioblastoma tumors compared to normal brain tissue strongly suggests the prevalence of effectively smaller scatterers within the cancerous tissue, as detected by the H-scan algorithm.
Smaller scatterers. And how does that connect to the biology of GBM?
We can link this directly back to glioblastoma's known cellular characteristics and its biological makeup. As we touched on, GBM is notoriously hypercellular. It's packed really densely with cells that tend to cluster together aggressively. These individual cancer cells are also often characterized by a higher nuclear cytoplasmic ratio compared to normal brain cells.
Meaning the nucleus is bigger relative to the rest of the cell.
Exactly. The nucleus takes up more space within the cell boundary. So this combination of dense aggregates of cells, plus these relatively large, dense nuclei potentially acting as primary acoustic scatterers or maybe even cellular fragments in areas of turnover. All these could contribute to an overall signature that the H-scan algorithm interprets as being dominated by smaller, effective scatterers, hence that less red, more bluish signature we see in the images.
So it's reflecting that dense abnormal cellularity and nuclear structure.
That seems to be the most plausible interpretation. And beyond just the tumor cells themselves, remember GBM also displays other features that influence the acoustic properties. Those areas of necrosis, dead tissue, the rampant vascular proliferation, abnormal blood vessels, and significant stromal alterations, changes in the supportive matrix. All of these complex microstructural changes likely contribute to the unique acoustic fingerprint that H-scan, via IWPR, seems to be so adept at picking up. It's essentially giving us a map based on this altered microscopic landscape.
And you mentioned earlier this trend has been seen before. Less red, more blue in other cancers with H-scan.
Yes, and that's what makes this finding even more compelling. This trend, malignant tumors exhibiting less red intensity or appearing more blue with H-scan, is remarkably consistent with previous H-scan studies conducted on other types of cancer. Researchers have observed similar patterns when using H-scan to differentiate malignant from benign or normal tissues in breast cancer, pancreatic cancer, and thyroid malignancies, as highlighted in those papers by Carol Seed, Yang, and Bake.
So it's not just a brain thing.
Exactly. This consistency across different tumor types and different organs suggests that H-scan might be tapping into some kind of fundamental principle or common denominator of malignancy. Perhaps certain changes in cellular and tissue microstructure that frequently accompany the malignant transformation, like increased cellular density, altered nuclear size, disorganized architecture, often manifest acoustically as a shift towards smaller predominant scatterer sizes, something H-scan seems perfectly designed to detect and display visually with that color shift.
That's fascinating. Now, it's important, you said, to reiterate that H-scan is primarily a qualitative approach, right? It's about relative differences, the color map, not necessarily giving an exact number for scatterer size and micrometers.
Correct. It's different from quantitative ultrasound or QUS. It's techniques which really aim to provide absolute numerical measurements of acoustic properties like scatterer size or concentration. HCAN is more focused on the visual relative differentiation.
But its main advantage isn't just being qualitative, it's that higher spatial resolution you mentioned compared to other methods.
Exactly. Its key strength seems to lie in its ability to display those relative differences in scatterer characteristics, the red versus blue balance, at a significantly higher spatial resolution than many other kernel-based QUS methods that might try to quantify average properties over larger regions. This means HGAN can potentially visually highlight those subtle but absolutely critical microscopic differences at tumor margins with much greater clarity and precision.
Making the edge clear.
Hopefully. And this capability could be incredibly useful for ensuring optimal delineation of brain tumor margins, guiding the surgeon towards achieving that maximal yet safe resection. Knowing precisely where to stop cutting is paramount, where the amount of brain tissue removed, or maybe more critically, the healthy tissue not removed, is of immense importance for the patient's neurological function, their future quality of life, and ultimately, their long-term prognosis. HGAN potentially offers surgeons a sharper, more informed scalpel, guided by microstructural information.
Okay, the potential seems huge. But if we step back for a moment, connect this to the bigger picture, while this study clearly lays crucial groundwork and shows immense promise, it's also important for us, and for you, the listener, to critically acknowledge its inherent limitations, especially when thinking about actually getting this into widespread clinical practice.
Absolutely. Critical thinking requires looking at the limitations. Firstly, as we discussed, the study primarily used formalin-fixed tissue. While the assumption that it preserves microstructure similarly to living tissue is reasonable for histology, future in vivo studies are absolutely necessary to confirm these findings in living, dynamic brain tissue during surgery. The acoustic and mechanical properties might differ.
Right, need to see it work in a living brain.
Exactly. Secondly, the source of the control tissue presents a practical challenge, as we noted. The normal brain tissue came from postmortem accident victims, not from adjacent normal tissue taken from the same glioblastoma patient during their surgery.
Which you can't really do ethically.
Right. Obtaining significant amounts of truly adjacent, healthy brain tissue during GBM surgery goes against standard, safe surgical practice. The goal is always to remove as little healthy brain as possible. However, this means that this specific study's ability to directly assess how well H-scan defines the tumor margin in a truly patient-specific intraoperative context is limited by the comparison groups used. Proving margin detection efficacy will be a key focus for future in vivo research designs.
Okay, what else? Any limitations from the simulation side?
Yes, a couple to keep in mind. The simulations assume that the acoustic impedance, essentially how much resistance the material offers to sound waves, was the same for all the simulated scatterer phantoms. In real biological tissues, impedance varies between different structures like cell membranes, nuclei, cytoplasm, matrix components. Future work will need to assess the impact of these varying impedance values on H-scan performance and IWPR calculations.
Makes sense.
Also, the current work relied on 2D simulations. While 2D simulations provide valuable insights and are computationally much faster, they are inherently an approximation of the vastly complex three-dimensional reality of tissue structures. Therefore, 3D simulations are already planned for future investigations to gain a much more comprehensive understanding of the underlying physics and the biological interactions in a more realistic geometry.
Get the full picture.
Exactly. And finally, the simulations generally use moderate scattering strengths and concentrations. The impact of very high scatterer concentrations like you might find in extremely dense tumor regions, and the potential for scatterer aggregation or clustering on IWPR's concentration independence needs further exploration. It's possible that at very high densities, the acoustic behavior might change, potentially affecting the IWPR measurement.
So, still some questions to answer there.
Definitely. Yeah. But despite these limitations, it's abundantly clear that this study lays crucial, really exciting groundwork for subsequent in vivo studies. Those are the essential next steps towards any potential clinical adoption down the line. And the fact that acoustic attenuation compensation had such a minimal effect on IWPR in this ex vivo setup is particularly encouraging, isn't it?
Yeah, that was surprising, but potentially very useful.
It suggests that maybe for superficial tissues, or when the ultrasound probe can be placed right next to the tumor margin during surgery, attenuation might not be a critical limiting factor for using IWPR effectively. However, for broader translation, perhaps imaging deeper structures or through more complex overlying tissues, some form of image analysis-based attenuation compensation might still be necessary. That needs more investigation. And ultimately, of course, a larger and more diverse sample size in future studies, both ex vivo and especially in vivo, will be absolutely essential. We need point-to-point correlation of the H-scan imaging findings, the IWPR maps, with detailed microstructural analysis from pathology on the very same tissue locations. That will allow for an even more granular and definitive understanding of what these precise color changes truly represent at a cellular level in different regions and types of glioblastoma.
More data, more correlation, more confidence.
Exactly. That's the path forward.
Okay. So wrapping this up, what does this all mean for you, the learner, listening in, and maybe for the future of medicine, particularly in this really tough fight against aggressive brain cancers like glioblastoma? This deep dive has shown us, I think, that H-scan imaging, specifically using that intensity-weighted percentage of red, or IWCR parameter, is a truly robust and incredibly promising tool.
It really does seem promising.
It's highly sensitive to those subtle changes in scatterer diameter. It's critically independent of scatterer concentration, which is huge. And perhaps most astonishingly, it seems capable of detecting sub-resolution differences in tissue microstructure that conventional ultrasound simply flies over. The significant, statistically undeniable differences found between glioblastoma and normal brain tissue in these initial ex vivo studies are incredibly exciting. They really offer a potential beacon of hope for improving the prognosis of patients facing what is still a notoriously difficult cancer. For you, the learner, this means being ahead of the curve, understanding a technology that could dramatically improve the precision and safety of brain cancer surgery in the future. It offers neurosurgeons the potential for a more accurate, real-time, color-coded map to literally paint a clearer picture of those critical tumor margins, ultimately enhancing patient outcomes in a way that current tools just can't seem to match. It's really about empowering surgeons with a new set of eyes, doesn't it feel like? Eyes capable of seeing the previously unseen microscopic edge.
That's a great way to summarize the potential. And perhaps this raises a final important question for you, the listener, to ponder as we close. Imagine a future, maybe not too far off, where during one of these incredibly complex brain surgeries, the surgeon isn't just relying on their trained eyes and tactile feel, but receives real-time, color-coded feedback directly reflecting the cellular level differences in the tissue they're about to cut. Imagine that IWPR map guiding their every incision with unprecedented precision. How might that level of insight not just, extend lives by getting more tumor out safely, but how might it fundamentally transform our entire approach to surgically removing the most aggressive brain tumors, really pushing the boundaries of what we currently think is possible in medicine?